Hi guys, I'm Lani, a first year medical student from Australia, and we are looking at a variety of things using mind maps. So, ranging from diseases to the actual processes that occur within the body, keeping us alive and well, and then also looking at how can internal and external factors affect our health. So, if you have any topics that you wanted to be covered by a mind map, please leave me a comment below or follow me on Instagram and DM me over there. So, without any further to do, today we are going to be covering creatine kinase, creatinine, and the estimated glomerular filtration rate. All right. To understand the relationship between creatine kinase, creatinine, and eGFR, we need to start by looking at this shuttle reaction here. So it consists between creatine kinase and phosphocreatine. It's a reversible reaction, and we need the building blocks of creatine for the shuttle reaction to take place. Where do we get the creatine initially from? So usually it is synthesized between the liver and the kidneys from L-arginine and glycine, and then this nitrogenous acid will be transported mainly to the muscle. We also get it on a secondary way, ingested as dietary protein. So this is how we get the creatine in the first place. Now, on average, we have about 120 grams per 70 gram male will be creatine in the body, and approximately 1 to 2% of that creatine is then broken down per day and excreted as creatinine. So creatinine is a waste product of creatine. Now, muscle mass represents approximately 98% of total body creatine. So that means if we have increased muscle mass, we are going to have an increased serum creatinine level. So we need to bear that in mind when we look at this level in patients, for example, between an elderly frail lady and between a buff athlete. So we do expect a higher serum creatinine level in the buff athlete compared to the frail little lady. Coming back to our shuttle again, the next key player is the creatine kinase. Now, the creatine kinase is a central energy metabolism regulatory enzyme, and we find it in the heart, the brain, skeletal muscle, and other tissues. And the levels that are normal vary greatly. So usually it's between 20 and 200 international units per liter, but it can be as high as 1,200 international units per liter in certain populations. Now, what is the function of creatine kinase? It catalyzes the reaction transfer of phosphate between creatine and ATP and ADP, and it's a reversible reaction. So, but coming back to creatine kinase, why would we be interested in measuring creatine kinase? So, creatine kinase is an indication of muscle damage because we see leakage into the blood when we have muscular or cellular damage, and this will lead to elevated levels. Now, there's no toxic effects if we have creatine kinase leaked into the blood. However, it does indicate that there is damage going on somewhere or that damage has occurred. So the measurement of the serum creatine kinase activity is an important indicator of the occurrence of muscle cell necrosis and tissue damage, and this could be due to a disease or it could be due to trauma. So for example, in an acute myocardial infarction, it will start to rise within 12 hours and then it peaks at 24 to 36 hours, and then it'll start normalizing again after 48 to 72 hours. We have different chains of creatine kinase. So we have the which mostly found in muscles, we have found in the heart and found in the brain. The second trauma, so to speak, that would release creatine kinase into the blood is called rhabdomyolysis. And this could be anything from a crush injury to extremely high intensity exercise. Presentation, what we would expect is muscle pain, weakness, and dark colored urine, which would indicate myoglobinuria. Now, the thing is, myoglobin is directly toxic to the kidney tubules, so that is just something to bear in mind. And then up here, we have our different levels to indicate moderate to severe rhabdomyolysis. So your creatine kinase will also be decreased in patients with connective tissue diseases like rheumatoid arthritis, lupus systematic erythematosus, reduced PA, and then elderly bedridden patients with reduced muscle mass, so they move a lot less. So when we have rhabdomyolysis, the most common complication to rhabdomyolysis is acute renal failure. Now, we talked about acute renal failure a little bit in the previous video, which I will link up above. And acute renal failure basically indicates a sudden decline in kidney function within hours or days, and it can be fatal. And symptoms include a decreased urinary output, edema, nausea, fatigue, and shortness of breath. But what it means in the big picture is that we are expecting a decreased glomerular filtration rate. So that is why our eGFR will be used to detect chronic kidney disease or your acute kidney injury, and therefore it's a marker of kidney function, this estimated glomerular filtration rate. So coming back to our shuttle now, how does the shuttle actually work? So we start with creatine. It accepts a phosphate group from ATP and it gets phosphorylated. So we have this storage molecule, phosphocreatine. So it's primarily found endogenously in skeletal muscles, and it's a rapidly acting energy buffer for the supply of ATP to tissues and cells like the brain, skeletal muscle, and heart, where we often need a lot of energy very quickly. Because what happens is, during muscle contraction, especially for that first 8 to 15 seconds of anaerobic contraction, your phosphocreatine will donate a phosphate group to the ADP, creating ATP anaerobically, and then going back to its original form, creatine. So that's why this reaction here will continuously go on in active tissue where we need that anaerobic ATP creation. So we've used the creatine. We're going back to the 1 to 2% that's broken down now into our creatinine, the waste product. So we see the creatinine in the serum, plasma, as well as urine. And the normal levels, it's usually very dependent on age, race, gender, body size, and it can increase if a person's dehydrated, if the person has low blood volume, or certain medication can change the levels. And also if a person had large amounts of meat. So remember, we ingest the creatine as dietary protein as well. All right. So creatinine, the only way it is excreted from the body or cleared from the body is by the kidneys. And it's usually at a constant rate, relatively constant rate, because there's minimal tubular reabsorption. And then we have this excretion in the urine. So the final levels in the blood and in the urine is basically equal to the amount filtered at the glomerulus. But here's the catch to it. There's also tubular secretion at the kidneys. So when we look at serum creatinine and creatinine clearance, we often measure it with a 24-hour urine collection. It comes with a little bit of a hiccup here because it can be incomplete. The person may forget to actually go in the container they're supposed to go, and it doesn't necessarily account for the active secretion by the proximal tubule in addition to being filtered by the glomerulus. So this can lead to false elevation of the creatinine clearance that's estimated and then used for the GFRs. Overall, though, it does give a good estimation of the GFR, but it can be decreased in low muscle mass, certain diseases like your muscular dystrophy, in aging, and it could also indicate some types of severe liver disease or a diet that's very low in protein. And also in pregnancy, we expect decreased levels. Another thing that we would be using creatinine for is the urea creatinine ratio. and it can be increased in dehydration or pre-renal failure, or it can be decreased in severe liver dysfunction, intrinsic renal damage, and rhabdomyolysis. So that's why it's an important marker for a lot of things going on in the renal system. So we've measured the creatinine now. What do we do from here? We have a specific formula that accounts for age, for gender, for race, even though right now they are still busy in developing a better formula to get a better eGFR, because there's so many variables. But at the moment, we would be looking at the Cockcroft-Gault formula, and that is just an example of that. Now, another way for the serum creatinine to be measured with a blood test, or it can be the Jaffa or the enzymatic method. Normally, these are the levels that we do expect in females and in males. So once we have the serum creatinine, it is plugged into a formula to actually estimate the glomerular filtration rate. The issue with the serum creatinine, though, is we only see changes in the serum creatinine once the kidney function has dropped significantly. So that is where there's a little bit of a sticky point in using serum creatinine. But our eGFR, the normal rate that we would be looking for in a healthy person, is greater than 60 to 90 mils per minute per 1.73 square meters. And just an interesting fact is aerobic exercise were found to improve the glomerular filtration rate. So there's a big reason to make sure that if you have a patient that has renal issues, getting them to exercise is an important thing to consider. All right, so that is it for this mind map today, and I hope to see you at the next mind map discussion. So please like and subscribe and share the videos with as many people as you can. And until then, map you later.